Good afternoon, everybody. It's now 2 o'clock, so I'd like to start the Health and Wellbeing Board meeting of the 20th of January 2026. Welcome, everybody. Right. Right. Just to say that this is actually a meeting of the council, so it will be live streamed and recorded. We are going to use the flagging system in terms of times of presentations to keep us on our time frames, which Dominic will put up a sign if we're coming towards an end. But you know, that doesn't mean that it's the be all and end of everything. If you just need a minute or two more, there will be flexibility to do that. Just make sure you stay in your respective places. Turn off your phones, and where'd that come from? Sorry. If you stay in your particular places, because then that will pick up your name for the live streaming, and then just make sure you turn your mic on and off when required. Okay, there are no planned fire alarms, so if they go off, it's the real thing. Okay, the officers will escort us out of the building if the alarms are activated. Right. If I can then just move on to apologies. So I've got apologies from Councillor Hartstein. Dominic, do you have any other apologies? Are there any other apologies?
Jill Burns.
Sorry?
Jill Burns.
Jill Burns, thank you, Sharon. Mark Tebbs. Alex Green. Thank you very much. If I move to agenda item 3, which is the minutes of November's board meeting, are they an accurate record of the meeting for those that were there? Is that a yes? Thank you. There are 2 ongoing actions. Board members were sent recommendations for future JSNAs by Benjamin, or they're supposed to be sent to you, Benjamin, is that right? So I just remind people to do that, and board members to review the contacts with Ben, if there are any additional contacts for future meetings. Is that correct, Ben? Future attendance, thank you. I've not accepted agenda item 4. I've not accepted any urgent items of business today, so I'll move directly to agenda 5. Are there any declarations of interest? I'll take that as a no. So I'll go to the first substantial item of the meeting, which is gambling harm strategy. So you'll find the report on page 11 of today's papers. There are 20 minutes has been provided for this item, 10 minutes of presentation, 10 minutes of questions. Right, and I just invite Rebecca to present her presentation, please.
Thank you, Chair. I'd like to present the Preventing Avoidable Gambling Harms in Thurrock Strategy and Delivery Plan. Gambling harm and gambling-related harm is a growing public health challenge with wide-reaching impacts on individuals, their families and their communities. The evidence shows that gambling harms extend beyond just financial loss, encompassing poor mental health, relationship breakdown, unemployment, criminality and increased demand on health and social care services. Thurrock has a significantly higher proportion of residents at risk from gambling harms compared to the national average, with an estimated annual social cost of 3.8 million, estimated by GambleAware 2024. And within the strategy itself, that has a breakdown of the figures and the numbers. For every individual experienced problem gambling, between 6 and 10 others will be affected. The strategy sets out a whole system approach to reducing avoidable gambling harms in Thurrock, aligns with national evidence and guidance, and it adopts a prevention framework across 3 main levels: primary prevention, which is reducing exposure to gambling opportunities and advertising, particularly for vulnerable groups and children. Secondary prevention, which is identifying individuals at risk early and providing timely, accessible interventions for them. And tertiary prevention, which is supporting their recovery and preventing relapse and meeting both the needs of individuals with lived experience and affected others. The strategic action is organised across 3 domains: awareness, support and regulation. The delivery plan focuses on evidence-based interventions, including targeted awareness campaigns, strengthened referral pathways in healthcare and council services, funding support groups and the adoption of robust local licensing policies to restrict gambling premises and advertising in high-risk areas. So the strategy requires sustained collaboration across local government, health services, education, community organisations and people with lived experience. Continuous evaluation and stakeholder engagement ensures that the actions are effective, equitable and responsive to emerging challenges. So we would like the board, the Health and Wellbeing Board supports the Preventing Avoidable Gambling Harm strategy and delivery plan for implementation across Thurrock. Thank you, Chair.
Thank you, Rebecca. Are there any questions? Margaret.
Thank you. Bex, can I just ask, I might have missed it in the report, how many gambling outlets are there in Thurrock? Do we know?
We do, and there is in the action plan, but it's actually not really so much about the gambling outlets because a lot of the gambling is online. Right. So along with looking at planning and premises, there's a piece in the strategy as well that looks at the amount of, if you took the national lottery out of the equation, what other online gambling is. And more worryingly, that often the triggers and the start of behaviour is with gaming online. Right. So I think if we just looked at the physical placement of betting shops and gambling licensed premises, we would undersell the problem.
Right. Okay.
Councillor Rigby.
Thank you, Chair. Thank you, Rebecca, for your report. I see that Thurrock has a higher than average number of gamblers, but there's not that many that are seeking support or in part. Do you know why that is?
Historically, public health hasn't held the responsibility for gambling awareness and gambling harms. And it's a very... it's not an addiction that is talked about. If I give you an example, in addictive services, working with opiates and alcohol users, they will admit their opiate and alcohol use on average 6 weeks before they will then open up about their gambling. So it's a very hidden addiction. I don't think there has been enough awareness and knowledge about how to ask the question about gambling, because if you don't put the training in place so people feel comfortable to ask the question, then people won't say that they've got a gambling problem, because it's one that they'd prefer to hide rather than face a lot of the time anyway.
Rob Percy.
Thanks, Chair. Can I just take this opportunity to just say thank you to Rebecca for leading the team on doing this piece of work, and I just wanted to bring to everyone's attention the table 2 on page 20 on the impact of gambling harms. Just to stress, whilst this comes to you as a public health led report and its preparation, the cross-cutting nature of the harms of gambling and how it affects society at all ages, across all domains. So there's a table there which shows the kind of the key problems that come from your physical and mental health well-being, the impact it can have on relationships, including domestic abuse and loneliness and child neglect, the financial impacts, and the societal ones around potential criminality, and homelessness, etc. So I just think it's worth emphasising, whilst it comes to you as a public health report, led piece of work, this has got a very cross-cutting nature, which to me seems to be something which is just worth being aware of in the work that we all undertake and how we take things going forward. So thank you for the work. I think the strategy and the evidence that sits behind it is really, really useful. It's difficult because, as Councillor Ruby just mentioned, there's not a lot of accurate data around what the situation is in Thurrock, so we have had to really take the national picture and just kind of multiply that, look at using a couple of indices around kind of Thurrock specific characteristics we know around deprivation, etc. But I think, you know, it possibly is a piece of work for us to look at kind of developing a more bespoke actions for certain areas, which maybe the neighbourhood work that we're doing and taking could help us to do some more work in that space over the coming period. Thank you.
Thanks, Bex. Really appreciate for the feedback for the report. I've got to say, just to note, we have seen an increase in number of patients with gambling that are being admitted recently. So there has been a shift on that, based on what Rob was saying as well, because of the disturbance in the psychosocial kind of circumstances, the impact it's having, people losing jobs, people's relationships, and so forth being affected, and as a result of that, the mental health significantly deteriorates. So we are seeing a trend in some of the cases that people are admitted because of that complex situation, because they feel their life is at risk. Yeah.
Thank you for that. Do you mind if I have a follow-up question to that? And I'll probably ask both of you the questions is, so what would you like to see in place to start prevention? So you've got a bit of an action plan. Actually, I'll just go through the questions and then maybe refer to both of you to answer them. As we talked about children, children seem to be at far greater risk at gambling than there ever was because of phones. It's about what actions, what steps could we take to try and reduce the risk to children?
Thanks, Chair. From our point of view, I would like to look at it as a prevention-based approach. So I think we need that access into schools. We need to be able to make school teachers and the children themselves aware of where the problems may arise. At what point is being on the phone problematic? Is it affecting how you live your childhood life? But also to make the parents of the children aware, because it could be that it's the parents gambling that is having a detrimental effect on the child. And if we train the teachers and the other school bodies and the pastoral care to be able to ask the question about are you gaming on your phone, because we know that's where one of the starts for gambling will come from, because it's not just the fact that you're playing games with your friends on the phone, it's chasing that win. So by putting some awareness out to all of the schools and getting the schools on board and the teacher and the training bodies, we took this to the youth council as well, and they thought it would be really useful to have some further training in schools, which we have started.
Sheila, can I ask if there's any ways we can actually get better access into schools to promote this issue?
I think you've already come to our DMT and we've had that conversation, and certainly our education colleagues will assist in any way we can to have this raised within schools. We've got a number of forums that it can be used in, so we've already made the connection, haven't we?
Something I'd really quite like to get an eye on, because I think access into schools, particularly around public health, has been quite challenging at times. So I think it's something we are really keen to keep on the agenda, Sheila. Okay, Ruby.
Just again, thanks to Bex again, and thanks to everyone who's engaging in the conversation. I think although we've got the strategy, the approach to it can get tweaked as we move forwards. This is a new area for us, so stay engaged, and I think we are learning as we're moving forwards with this, and are happy to take further feedback as we move forwards with this, move forward with this strategy. So taking a slightly iterative approach as well, I think, and learning from it.
Sharon.
Yeah, and just going back to the kind of children and schools issue, I mean, obviously, if the government, if what happens today is going to happen, then maybe in 12 months' time they might not have access to some of these sites anyway. But in the interim, it's just schools, their policies around phones in schools as well. You know, obviously, kind of any time you're reducing for a child having access to the phone, or the possibility of accessing these websites, you know, schools, what are schools doing in Thurrock around some of those policies around use of phones in schools?
Thank you, Sharon. I guess that's down to individual schools, though, isn't it, and their policies. Maybe we can take that back somewhere else. In terms of businesses and raising awareness in businesses, have you had much contact with local businesses in Thurrock?
We have had some contacts with a few businesses, but I think where gambling harms differs from other addictions is a lot of businesses have funding from gambling levies or gambling monies. You know, so it can be slightly more difficult. If we were going to go into a pub, a lot of pubs have fruit machines in there. There's some sponsorship there. So businesses themselves, yes, we can access, and it's part of the action plan. But it's sometimes some of the businesses that we really need to engage with. That will be the harder work. We'll do it, but it will be the harder engagement.
Thank you. And I guess my last point is really about planning. Have we spoken to our planning colleagues about licensing of betting shops, etc.?
Yes, planning and licensing sit on the forum, the Gambling Harms Awareness Forum. So we have Paul Adams primarily who sits on it, but brings Elizabeth Cox as well. So we have a good overview of gambling licensing as well.
Unless there's any other questions. Kim?
Thank you, Chair. Thank you. It was just really to ask whether you've linked in and spoken to citizens' advice over, because obviously we run that reception area, and the amount of people that come in with debt related to find out that it was then related to gambling, and obviously the amount of food bank vouchers we're giving out when people haven't got money. Some of them are quite open about the fact that they've gambled it and whatever. But it was just really to say we've got young Health Watch ambassadors, and we do get out into the schools a lot, and we have young ambassadors in the schools, and they quite often will talk to other young people. So it is a link in with the young people. They meet, have a subject, and they go to a lot of it is around mental health, but that would be a really good thing because they do mention it about young people gambling on the phones and even gambling between themselves over bets on things, normally football and stuff. So I suppose it starts quite young, really, doesn't it? But just to say there is that forum if you needed a voice in there for young people to ask young people.
Could I link our training and awareness in with those young people? With the young people, we have advertised it widely, but the more people that can do the training and awareness, so maybe we'll get a specific group in. And following on from what you say about debts, and the other thing that we don't know, we know that gambling affects people's mental health. We know that some people don't know of a way out, but we don't know how many suicides or attempted self-harms are a direct result of gambling, because it will be put down as mental health, but it could be a direct link to gambling. So there's a lot that we don't fully know yet, which is the idea of this strategy, is to learn more and to engage more and to help more.
Thank you, Rebecca. Councillor Rigby?
Thank you, Chair. Rebecca's just sort of answered most of what I was going to ask to Matt, to follow on where he was saying about the increase in admittance recently because of the spiralling, as to how big a proportion is is down to gambling as the primary reason, whether you're sort of establishing that. I know that Rebecca's just alluded to that. That's something you've got to look into. But
I think the causal is very complex. So, but its impact quite often is because they're not being able to actually share that stress with the loved ones. So they've been absorbed by themselves. So as a result of that, there's a lot of breakdown, and people feeling very distressed, feeling that obviously putting their life at risk, for example. That's the only way they can see it, and so forth. And for mental health, there's so very little you can do, because it's the lifestyle, this is the behavior, and change people's way. And it's almost like you're treating an addiction, isn't it? So it's time consuming, and also quite often these people expect you to do a very quick fix. So therefore, for us, it's about giving that space, that time, and also if we need to engage with the family as well, if with the permission, so that they have a safe space to do whatever the dialogue they have to engage in. Yeah.
Okay. Any other questions? I'll just say, Rebecca, thank you so much for your report. I'll be quite keen for you to come back later with an update on the work you've been doing and your findings of any further data, particularly relating to Thurrock. So thank you, and if it's okay, I'll move to recommendations.
Thank you, Chair.
So it is recommended that board members support the Preventing Avoidable Gambling Harm strategy and delivery plan for implementation across Thurrock. Is that agreed? I'd like to hear it. Is that agreed? Thank you very much. Okay, thank you, Rebecca.
Thank you.
Okay, so if I move on to the next item, which is the ICB strategy development. Is that correct?
Yep, that's correct. Thank you, Chair. I was going to focus on, I'm sure everyone's read the pack, and so I won't go through every single slide, but I was going to focus on two slides. So the first one of those is page 52 of your pack, just to kind of give a bit of an overview in terms of how the NHS is starting to approach planning for next year and beyond. And as board members will be aware, you know, we're seeing a lot of kind of structural change in the way the NHS operates, not least at the ICB, and so there is quite a lot of flux going on at this moment in time, not least actually around some of the timeframes which are set out within this slide, which have moved on a little bit. But what this slide kind of intends to sort of illustrate is the approach that it is expected for ICBs to follow and work through in partnership with partners to develop the plans for the NHS in their area of responsibility, which for us will be Essex from April. And so we are doing the planning for next year on a whole Essex footprint, so Mid and South Essex, West Essex and North East Essex. And so the sort of staged approach which is set out, and this will be iterative, is firstly, you know, starting off looking at the integrated needs assessment, so looking at the existing JSNAs that we've got across the different parts of Essex, working through what are some of the key issues and outcome areas that we know that we need to improve on within Essex, which is reflected a little bit later on in the pack, and therefore how we might want to focus our work and our efforts as we move through the coming years. That will then flow into kind of a 5-year strategy, and so that strategy should and will kind of set out what are the outcome ambitions that we want to set out in terms of improvements for the people of Essex, and then mapping that through to a set of coordinated delivery programmes that will be delivered by different parts of the system and in partnership with different parts of the system and the public sector. That will be a document that will be reviewed and updated annually, and then that flowing into the Population Health Improvement Plan. Effectively, that is the delivery plan. So what is it that the ICB is going to do in terms of making a difference to patients in the way that it commissions services? That will also be the new joint forward plan for people who are familiar with previous versions of sort of NHS planning architecture. The JFP will be replaced by the Population Health Improvement Plan. We're working through that at this moment in time. I think where we anticipate to be in February is in a place where we've got kind of a good working document, and we're kind of quite clear in terms of what we think some of the focus areas for 26-27 is going to be, but we know there's going to be a lot more work to do to think about and work through future years. Flowing into that, which is going to be an area that we'll particularly need to work with this board on, is the development of neighbourhood health plans. So how is it that we want to go about the development of the neighbourhood health service here in Thurrock, and how do we want to build on the good work that's gone on, but equally where can we learn elsewhere? And so we will be moving in the coming weeks into starting to think about what do those neighbourhood health plans look like. What are the areas of focus that we want to look at, and how will some of the other changes that we know are coming down the line, so the changes, say, to the Better Care Fund and things like that, align to the delivery of those neighbourhood health plans. So that's sort of the architecture. And then our initial kind of thinking is on page 64 of the pack, and so the table on 64 is designed to really start to try and flesh out kind of some priority domains, and then how key service areas and outcome ambitions map to those domains. And so the priority kind of domains that we've identified so far is firstly around reducing health inequalities, so something that needs to be wound through and reflected within all of our activities as an organisation. And so how do we effectively take action to reduce life expectancy inequality gap, but equally also healthy life expectancy inequality gaps that we know that we've got at this moment in time. The work that needs to be done to look at where we've got variance in terms of the access to services, and so for instance we know that general practice access isn't as good as it needs to be here in Thurrock, and so what is the work that we're going to need to do to resolve that. We then move on to living, where particularly thinking about long-term condition management, particularly thinking about some of the wider access challenges that we know we've got around areas in elective care and cancer, and then moving through ageing, dying, starts, minds and response. So that's our initial thinking, which I'm hoping we can get some feedback on that today. And then you can see on the other side of the table where we set out in terms of some of our initial thinking around some of the outcome ambitions. But this is very much here for a bit of a discussion. Be great to get feedback, and it's something that once we've got developed we'll want to flow through this board.
Thank you, Tom. So now time to go for comments and questions. Rob.
Yeah, so can I just say thanks, Tom. So when I looked through these the other day, can I just say it's really quite exciting. So there's a nice crossover for me, an interface with the council's agenda around wellbeing and social care, public health. So I've got a specific question about the priorities and outcomes of the population. That was really good because that really closely aligns potentially to how we're undertaking the health wellbeing strategy in Thurrock, the refresh of that. And so I'll just pause there and see if there's any more comments that want to come in around the health wellbeing strategy production going forward. But my specific question was linked to the planning overview and the 5-year strategy. So one of the challenges that we've had in local government for a long time across successive governments, particularly out of social care, is trying to make that case to DHSC around a long-term financial settlement so that we can plan for the longer term and have an idea of resources. In putting together your kind of 5-year strategy, which I'd see very much kind of interlinking with our health wellbeing strategy, the strategies for health wellbeing across in the future of LGR, etc., Have you had any discussions? Where are the Treasury and the HSC as far as kind of you being able to sign up to a set of priorities that funding will follow for coming years?
It's a great question, Rob. So we've had a 2-year allocation notified to us, which is good because it had been annual allocations before then. The DHSC and NHS have committed kind of early in the new financial year to try and get us the kind of years 3 to 5 as well. And so I think once we get that, that will be really helpful. The other sort of complementary piece to that is not just the revenue allocation, but also the capital allocation. So if we think about neighbourhood health and the development of the neighbourhood health service, we're going to need places to deliver in neighbourhoods those services, and we know that we've got some particular challenges locally here that we need to resolve. And so if we can get that confirmation and clarity alongside the revenue, we can start to think about some of those enabling activities around estates, digital, other things that we're probably going to need to do in order to make all of this an actual reality on the ground for local residents.
Any other questions?
Hi, thank you. Really interesting report. Notice there's sort of where it says biggest drivers of early mortality. You know, Thurrock is worse in most of these indicators, just across Greater Essex, but also nationally. So, is there going to be any particular focus on that? Because obviously, that's a bit worrying.
Indeed. So yes, so and it strays a bit actually in terms of my second item actually. So one of the things that we need to do and want to do is, as we start to think about the new Essex footprint, is well two things. So the first thing is working through sort of what I'm calling the universal service. So what is it that every resident of Essex can expect from the NHS? And then, but then alongside that, what is the differential level of investment we're going to need to make in different parts of Essex where there's significant inequality of outcome, and start to for the unwarranted variation, we can start to try and tease that out and resolve that, but then start to think about how can we join up to tackle some of these issues, and recognising that we won't just be able to do this within the NHS alone, because actually a number of the factors that underpin kind of poor health outcomes aren't necessarily aren't resolvable through health interventions. So how do we tackle some of the challenges that we know we've got around housing and things like that, and how do we work in partnership with colleagues like in the council to get a much more coherent approach to that? Now I think within Thurrock we've got some really good ways of working in terms of the existing neighbourhood teams, and so we've got lots we can build on, I think, locally here.
Ruby?
Thanks for sharing this. This is great to see and really support the outcomes. I think kind of taking a wide population approach. Just a kind of few points. So I guess one, recognising super tight timeframes for things to be happening over the next few weeks, and would kind of offer, if there's other opportunities to engage in, especially the neighbourhood work, then we're willing to and would like to. I guess the other kind of small point on the first priority outcome around inequalities, I guess when we're thinking about services equity as well, so small subtle difference, but just thinking about equity of service provision. Really welcome the fact that obesity is in here, and you've kind of mentioned wider determinants. Will you be taking a kind of broader, wider determinants approach? And another topic, which is kind of in the NHS 10-year plan, is tobacco, and it's still the biggest cause of health inequalities and a biggest driver. And is there a focus on that or less of a focus on it?
So I think we need to. So I think in terms of yes, around we need to take a wider, broader determinants approach. The question that I don't fully know the answer to, and it's probably an offline conversation, Ruby, is we've talked about it for some time, but we're not necessarily making the progress at the speed that we want to in that. And one of the things we will need to think about, I think particularly once we know outcome around LGR, is where are there going to be the opportunities for the ICB, which will be a smaller organisation come April, to join up and integrate the way it commissions with councils, and so we can kind of embed that approach, and so it sort of is it's very much core of what we do, because I don't think we within the NHS are necessarily the best placed in order to resolve some of those challenges. And we'll talk a bit about kind of the convener model and our thinking around that in the next item. But we need to work through an approach that communities will know what works and what will work for them. And we need a better way of us being able to access that and understand that and enable communities to solve some of those problems with support from us, as opposed to us going in and giving them a prescription. And so I think there's some opportunity to think structurally about how the ICB works and integrates with others as we move forwards, because we will need to, given the scale of the challenge that we've got and the resource that we'll have to deliver on all of this work. And then on tobacco, tobacco, yes. So tobacco does remain a priority. We need to, so I think we're going to want to work very closely with you and the other directors of public health around how do we unify our kind of approach across Essex, because it's very different in all parts of the Essex at the moment, which might be valid, but there's probably learning we can take from different parts of Essex in terms of our approach around tobacco.
Okay, if I go to Councillor Rigby and I'll come to you.
Thank you, Chair. Thank you, Tom, for the report. So a lot of the prevention ideas, obesity, tobacco that Ruby alluded to, the whole system, is quite a long-term aspect. So there probably won't be an awful lot of change in those areas in the 5 years. So are you going to sort of work more at pace of the other things in the prevention, like increasing access to services? Because although that background is important, I can't see that there's going to be significant changes in those in the short term.
No, you're right. Well, it's a both, isn't it? It's not a either or. So I think whilst we work on that within this work, that we need to. I suspect that we're going to have a really big focus on frailty management and end-of-life identification and support next year. Equally, we also know in terms of some of the long-term condition areas, so secondary prevention, so diabetes management is not as good as it needs to be in most parts of Essex. So there's some areas that we can move on right now, and in doing that we help improve outcomes, but equally also we can reduce some of our reliance that we've got on hospital services, because we're not seeing the same instance of crisis and then people presenting as emergencies through the NHS. And so I think we're just trying to work through some prioritisation at the moment to say these are the areas that we think that we can make a real difference. There's a really clear evidence base in terms of what works and how we can measure success or not. And so yeah, I think we'll be doing both channels, I guess, because that long-term stuff will ultimately guarantee long-term sustainability, but we can't wait for that to happen. We've got to actually do something in the here and now.
Sheila?
I'm just looking at the overview of draft commission intentions and sort of thinking of children, young people, and it sort of links to the acute hospital, because obviously you've got concerns about some of the CQC assessments, particularly around maternity, and also learning disability, autism. We've had a recent SEND inspection, as you've had the draft. It's not published yet. We had a draft report, but there were questions raised about resources for diagnosis, for treatment, around neurodivergent young people, children, and obviously that impacts then on your adult population, because they come through and hopefully become adults and then have those issues as well. So I think, like you said, the answer to the Thurrock having more issues, will there be some sort of prioritisation here? Because I think, some areas need a fair bit of attention, perhaps more than others, and I think some of those areas do need it.
Yes. So actually, we had our executive team meeting this morning. Actually, we were looking at having that exact conversation about prioritisation, and children came up in terms of how do we improve the offer for children, particularly with neurodivergence, and how do we also standardise the offer as well, where there's difference at this moment in time. So yes is the short answer, and I think Giles is going to probably be in touch with you, Sheila, in terms of like how that's shaping up, so you can share your views and make sure you think it's hitting the right. We're approaching it in the right order.
Right. Thank you. I've only got a few minutes left, but I'll just want to really say I'm actually quite excited by this as a great opportunity to really look at how we can develop our neighbourhood services, how we can learn from other places, not just in Essex, but I mean, I think we've had a conversation before, Tom, it's actually trying to have the race to the top, learn from Southend, learn from Essex, and hopefully we've got some positive things to offer them. Your approach seems to very much match what the council's trying to do in terms of developing its 3-year strategy, and hopefully they will mirror each other so we're not at odds with each other. So I'm quite excited by that. And I think that we're about to publish our ward reports, which I think will help us plan services. And I'm really interested in any data you could share from health with us about how we can actually look at our communities and how we look at sharing data to provide better services to people from a social services point of view as well as from a health. So I'm overall really excited by this opportunity. Is there anything you want from us as a council?
I think at this stage, comments. So I think do feed through your thoughts in terms of what do you think we're missing, where there are opportunities you think there are for us to join up in terms of where, particularly like where we've got existing programs of work or thinking going on around the strategy work. I think as we move into the new financial year with the creation of the new ICB, then starting to think about what might be some of the ways we might want to start to formally integrate some of our commissioning activities between what the ICB's responsibility and the council's responsibilities. But yeah, I think it's an opportunity to, if we get this approach right and we get the core strategy right, recognising it will change, we can then think about how do we deliver it together. And I think that's where I would like us to get to.
Thank you. I'll just bring Robin and then I'll move on if that's okay.
Yeah, so can I just add, to fully support Tom's comment, I think this is a real opportunity for us to align better our work going forward. So my little question, I generally don't would see your just a clarification of this one, is in the strategic planning overview, the work you're doing around what you're calling the integrated needs assessment, yeah, is making sure that we don't duplicate as well. So the work that we're doing around the joint strategic needs assessment and is making sure that we're dovetailing what you're requiring to do there with what we're already doing. Actually, let's try and do it once across the organisations. So can I just check that interface is happening? I've noticed the timeline on that, which is quite tight.
So yeah, so I think for the work that we're doing for this current kind of slightly kind of condensed time frame is we're drawing on what we've already got, so the existing JSNA products that we've got currently across all of the councils in Essex. Now I think as we move forwards, I think we'll want to refresh that. I think if there's more information coming out about ward profiles and things like that, and then what we need to distill is what's the Essex-wide priorities in the Essex-wide piece of work versus what is the very much more specific neighbourhood work that will be delivered much more locally in individual places. And so we can be clear around that in terms of where there's an opportunity and it's logical to deliver something at scale on the kind of Greater Essex footprint. We do that, but actually the principle of devolution is going to be core, I think, to our approach.
Okay, Ruby. Okay.
Sorry, we probably do need to have a separate conversation, but just there are a number of obviously regional dashboards which are really helpful, the POF. And I guess just to say we will be, just to follow on from Mark's point, we will be this year looking to build a dashboard for the INT kind of level, looking through that frame. So I think that would be helpful to kind of have some working with yourselves, with the NHS, to make sure that that data going into that is beneficial for everyone.
Okay, that's great. So if I can move to the recommendations, and the recommendation is that the board note the updates. So I think it's noted, and thank you very much. So if it's okay, I'll move on to item 8, which is neighbourhood health update. Are you presenting that as well?
I am, yes. Although Margaret might want to jump in too. So I thought just a very quick update in terms of some of the changes going on within the ICB and where we're at. So as I think everybody knows, we are still on track for the formation of NHS Essex, which will be the new ICB that will cover the whole of the Greater Essex footprint on the 1st of April. As you know, we've been going through a process, firstly with the kind of senior executive leadership around the appointment of that team, and that was completed last year. And we have now closed our wider staff consultation around the future structures of the ICB last week. We are currently having a look at all of the feedback. We've received fantastic feedback from partners and from all of our teams within the ICB. But the aim is to publish the outcome of that consultation at the beginning of February, and then to move into an appointment process into that new structure. That will take us through to the end of March, is the plan. So we aim to be in a position come the 1st of April. We've got the new organisation fully set up and we've got people in post. But alongside that, clearly what's really important is that the Essex ICB is going to be a new organisation with a new purpose, given the changing role of the ICB. And so firstly kind of wanted to share some of our thinking around the mission and the work of the ICB and how we might start to construct our vision as an organisation. And so we've set out kind of the 6 C's within the document as sort of, which we'll be really keen to get people's views on, and we've tried to expand that a little bit in terms of collaboration, convening, core, commissioning, community and care. That's really just to help us think about the culture and the ways of working that we're going to want to hardwire into the new organisation. Alongside that, we've also been doing work around agreeing, or starting to agree, the neighbourhoods of Essex. And so we know a core component of the yet unpublished guidance around neighbourhood health is that we need to be clear around what are the neighbourhoods of Essex. And so we've been doing engagement across all parts of Essex around the agreement of that. I think for Thurrock, I think there isn't proposed to be a significant change in terms of the current kind of existing footprints that we've got in place. I think there was consistent agreement across all partners who were involved that actually they work, there's some great team working and we can build on top of that. Also, they are sort of geographically coherent and make sense to local residents as well. And so our current plan, admittedly it's still draft and will come through for more formal approval in due course, is to maintain the current neighbourhoods as we currently have here in Thurrock. What that will enable us to do is, once we're clear around how the capital financing will operate for the neighbourhood health centres, it will put us in a good place in order to be able to apply for that, for access to that capital financing. And we can definitely think about how we can use that to accelerate some of the plans that we've currently got in place locally. So that's where we're at in terms of the neighbourhoods. The other thing we're starting to work through is what is the potential shape of a neighbourhood health contract. So the way in which the ICB will look to deliver the neighbourhood health service, given our change responsibility, is through some form of commissioning arrangement. And it's still very early days, so we're engaging with a whole range of providers at the moment around the options around that. We've been talking to GPs and starting to think about what we can learn, to your point, Chair, around things that have worked well, both in Essex actually, but also nationally and internationally around kind of these sort of contracts. But what I think I can say building on what I was talking about earlier, is I think that contract will have two core components. So there'll be a component around the universal service. So what is it that every resident of Essex can expect from the NHS in their local area? But secondly, a more outcomes-based contract, which starts to think about certain target cohorts of population and thinking about how they can work how we give flexibility to those providers to work differently to best meet those outcomes. So moving away from us being an organisation that sort of specifies you do this on a Tuesday, you do that on a Wednesday, actually saying what we want you to do is to do good things that deliver these outcomes to local residents. Quite how you organise yourself to do that is up to you, because actually different communities will need different things. And a big question for us is how do we hardwire into those contracts the expected governance and leadership arrangements. So making sure there is clinical leadership in place, thinking about how is the community and voluntary sector involved, how is the resident voice also heard within that, as well as other public sector partners such as our local authority colleagues. So it's a lot of work to do, but our hope is over the course of the coming financial year we can start to trial something and see how that works. So that's potentially quite interesting and quite exciting. Alongside that, I apologise to Kim because she'll have heard me say some of this at the CVS AGM just before Christmas, but we're also thinking about how do we reset our relationship with the voluntary and community sector more broadly. One of the things I've heard, particularly having since securing the Essex job and talking to a number of organisations who work within the sector, is that we have inadvertently, through the way in which we have kind of issued contracts or grants and things like that, set up the sector to compete with each other as opposed to collaborate with each other. And because, to Rob's point around the way that money's flowed, we've also done everything in a very hand-to-mouth way in terms of everything's 12 months, 1 year contracts, and so it gives a huge amount of uncertainty. So what we're exploring is changing that approach quite fundamentally, and so what we're describing as a convener approach, and so starting to think about what is the resource that we've got available and some of the problems or difficult issues that we're trying to resolve around a particular cohort of population or particular issue that we face, and then working with the sector around how can they work together to solve that problem, and then how can we flow the money through that arrangement on a more sustainable basis. We've got some very early kind of thinking going on around sort of vaccination uptake in terms of the cohorts of our communities which aren't routinely accessing vaccinations. I don't think, doesn't matter how many text messages or NHS app notifications you get, you're probably not going to do that. We need to think about how do we work very differently with those communities, and I don't think in that case the NHS is the best organisation to do that, but actually thinking about how do we work with community groups. But equally you can see how it could apply in a whole range of different areas. So so we're thinking about that at the moment. So we're doing some initial trialling work. We're being supported also by the Essex Community Foundation as well, who are setting up a number of sessions across Essex for us to talk to the sector and to listen to the sector about what works well, what doesn't work so well, what do we need to change. The first one of those is in Harwich tomorrow, and then we've got them. There's another in Harlow, isn't there? I can't remember exactly where they all are, but I'll if you're interested, I can get the dates to you. But again, for next year, I'm really keen for us to think about how do we start to reset that relationship with the CVS sector and begin to work quite differently with them to help kind of enable both their sustainability, but equally actually better kind of outcomes and better results for residents. And then finally, also just the other thing to say is we're also very conscious of what the changes to the NHS have brought to other partners, not least Health Watch. And so we are having conversations with Kim and the other two Health Watches in Essex to work through how can we work better together, but equally also potentially the opportunity of, given our changes within the ICB for Health Watch, to potentially support us in terms of understanding the views of residents, given that we're not going to have the same level of resource internally within the ICB to do that, and indeed actually Healthwatch is probably better placed to do that than we are within the ICB ourselves. So this is here as a bit of an update, Chair. I think we'd be really happy to take any comments and questions around sort of the emerging vision and the 6 Cs, and indeed any kind of contributions and thoughts around both neighbourhood development and the work that we're doing around working with the voluntary sector.
Thank you, Tom. That's great. I'll go to Rob, and then I'll ask if anyone else has any further questions.
Thanks, Chair. So let's all be honest. Let's not underestimate the scale of the challenge that we've got going forward. And but on that base, I would just want to say how much this dovetails with the direction that we are pursuing as well. So this is a real opportunity to do integrated work and go forward. And I think really from a population point of view, if anyone is listening on the webcast at the moment, members of the public, sometimes this can all sound quite intellectual, sometimes we go into acronyms, but fundamentally this is about trying to improve the well-being and the health of our communities. And so there's just 2 observations. I think the convener model is a really interesting one. So I think that convener model is actually a vehicle that we could engage with around doing more developed joint commissioning, particularly with the VC. And I think linking back to your previous presentation, Tom, linking back to what this means from a population point of view, one of the great benefits for me was if we could really improve our approach, our focus on prevention. And that's where this could have a real opportunity in really supporting preventative work. So I just think, if we could look at trying to do something meaningful around the community approach as far as delivering prevention and working with the VCS as a really good medium to be able to kind of take that work forward. And then just one observation from the National Children and Adults Conference we went to the back end of last year, which received a cross support across political parties and across sectors, was some talk about rather than calling them, we've had integrated locality teams here, as you know. We are very much exploring the consistent approach to call them integrated neighbourhood teams. But one of the things that came out from the national conversations was the idea around an integrated neighbourhood and wellbeing team, or neighbourhood and wellbeing, which kind of embeds that wellbeing philosophy in everything that we're trying to do. And so I just throw that in as something that that I think would be worth a joint discussion, worth consideration of going forward. So I think these are providing the right foundation blocks for us to really build on all the good work that already takes place in Thurrock. And so I really welcome the paper. Thank you.
Thank you, Rob. Councillor Rigby?
Thank you, Chair. Thank you again, Tom. So you alluded to engaging with communities, the challenges with vaccines. The whole sort of idea of this is going to be getting into communities, promoting prevention care. James and I touched on it just before the meeting about perhaps, how you would do this, and I thought, could maybe use role models. What sort of areas are you talking about? I know you work a lot with Healthwatch, that I'm sure will be greatly involved with this, but I think that area is going to be more challenging than perhaps forming, partnerships with the council and other areas. I think it's really going to be getting into the communities, and that's going to be such a big factor for this to work, isn't it? Yeah.
It is, and that's partly the thinking behind the approach. So rather than us trying to get into communities who won't necessarily trust us, potentially for good reason, actually how can we work with the organisations that are already working in those communities and who are trusted, and understand why somebody doesn't want to have a vaccine or whatever, the challenge or the issue might be, and help us in terms of understanding what do we need to change to make that service accessible to that individual. Is it an issue of trust? Is it an issue of access because of where we're currently providing the vaccines from, in the vaccine case, etc., etc. So it's using the people who are already trusted in communities and working in communities to help us, as opposed to us trying to go into a community who doesn't know us, and so that's I think the change in approach that I'd like to try and bring about, because I think that will deliver much better results, and indeed will support those organisations working in those communities, which is really important in terms of actually to that point around wider determinants and everything else. So yeah, that's the ambition. I'm sure. Well, as I said, we're going to trial it out. We'll get it wrong, I'm sure, the first few times, but actually we'll learn from that and we'll adjust it to as we move forwards.
Have you started that trial yet, or is that in?
James has been working on this, so I don't know, James, do you want to say a word about where we're at?
Thank you. We will be hopefully starting the trial probably the second week of March, targeting the advanced MMR, so includes chickenpox, shingles and unvaccinated mothers. It's purely a proof of concept exercise to look at how the ICB can devolve money to a non-ICB led entity, so in this case a collection of voluntary sector groups chaired by the Community Foundation that will then turn the money around in the form of community grants rather than the very overly prescriptive tender process that Tom explained. If that then worked on those very narrow, clearly defined cohorts, then we can take the convener model and take it out to you all, hopefully in October of this year, for a formal consultation. And then the intention will be early next year, we'll look at commissioning something, hopefully on the footprint of the new unitary authorities, so that convener model has as much coterminosity with local government friends as humanly possible. But when we have the early results that we're hoping one of our academic friends will validate for us in terms of return on investments, quite happy to take those results either back through here or through HOSC.
I've got a couple of points, if it's okay. I'm really pleased to hear that you're looking at working with Health Watch, because I think they're very important in terms of being a voice for the people we're here for. So I'd encourage you to do that. My question around neighbourhoods, particularly in Thurrock, as we've got a large growing population, is how does that affect the neighbourhood shaping? At the moment, I feel very comfortable with it in terms of the PCNs, but there are some parts of Thurrock growing larger than others. So I just wanted to see what we meant by neighbourhoods. And neighbourhoods seem to be a theme at the moment, in the sense of what is a neighbourhood. Because when we talk about neighbourhood health centres, we're talking populations of 250,000, not populations of 50, 60,000. And how do we consider that in our thinking, particularly around joint planning, around what is a neighbourhood?
Yes, so we haven't, in terms of the neighbourhood work that we've been undertaking, we haven't been overly prescriptive around population size, and so the test that I've asked everybody who's been working on it within the ICB to focus on is it recognisable to the people who live there? So if I take an example in terms of some of the current thinking, so Canvey Island, for instance, is a very recognisable community. It's a very recognisable neighbourhood. People who live in Canvey say they live in Canvey. That's got a population of about 35,000, but it doesn't make any sense for us to extend the Canvey Island to get to an arbitrary population number. Equally, say somewhere like Chelmsford is being proposed to be a single neighbourhood, despite the fact it's got a population of about 100,000. But actually, people would say you live in Chelmsford, right? So I think we're being a bit flexible on that particular question. Now, what we'll need to work through as plans advance around kind of future population growth, future housing growth, we do need to overlay that onto our neighbourhood planning, particularly when we start to think about any new refurbished, expanded facilities, etc., to make sure that they're A, sufficient, but B, also located in the right place and are accessible, because clearly if we want to make sure that any neighbourhood health facilities that we're creating are accessible to the people in that particular area and where they live. So But yeah, I think it'll be something we can keep under review. But I don't think we should be too worried about if it gets a bit bigger than 50,000. If it still makes sense for it to be, 60, 70,000, I think that's absolutely kind of fine and could be supported.
Maybe.
Thanks. Just a couple of comments. I'm really just want to make the point. I'm really delighted, kind of close working with VCS. I think you kind of hit it on the head when you talked about trust, because I think that is the absolutely what's at the heart of some of the challenges, not just with NHS, just more broadly with public sector organisations. I think immunisations is a particularly complex challenge. There's a lot we're not in control of on social media that influences people's opinions on a wide range of health matters, and a lot of misinformation out in the public as well. I'd be keen to see how that progresses. And I think just part of this, I think in my mind, there's a little bit of an overlap around those marginalised communities, inclusion health groups that find it difficult to access, and I guess just recognising the diversity of different groups, and really keen to see the learning back. It will be useful for everyone in this room.
I just have one other question. There's so much good work going on here. I'm hoping we don't miss some of this as we try to look at it in terms of a local plan and how that's feeding in. Do you feel you're getting the opportunities you need to present your views and your approaches within the local plan?
I think so. Yeah, I think so. I think the working relationships locally here are good and solid. So I think there's definitely we need to continue that, don't we? As both of all of the planning work develops. But I think we've got the mechanisms in place locally here to make sure that they are, as Rob says, mutually supportive and kind of nested to each other, and so they work effectively together, and we aren't creating tension unnecessarily.
Okay.
I was just going to say on that, the ICB is doing some work with your place teams at the moment to look at, once we get the LGR announcement, what are the areas in the neighbourhood PCN areas that will then suddenly potentially become infringed by other planning areas. So if you think about the Stamford and Corringham PCN, takes in Orsett, Horndon and Balvan, obviously those communities physically closer face Brentwood. So if there was significant development in that portion of Brentwood, it's likely that the pressure would be more borne on that section of Thurrock. So once we get the LGR announcement, there will need to be conversations with regards to, in the context of the new unitary, are our neighbourhood PCN areas still basically self-sustainable and self-contained, or are there logical areas in which we may want to share some cooperation? So as a part of the neighbourhood planning, we've already specifically started conversations. I had a conversation with Alex Powell here this week about ensuring that our neighbourhood governance creates space for local government, and equally we'll free up resource to ensure that we play a part in anything that you want to do in terms of your neighbourhood delivery committees. So that way, even if we don't get precisely the same geography all of the time, we hug each other as close as possible. So ideally, we create those appropriate fora regardless of the LGR outcome.
Thank you for that, James. That's really helpful. Thank you. Right, I don't think there's any other questions. So just again, thank you, Tom, Margaret and James for coming along today. And if I just move to the recommendation, which is that the recommendation is that the board members note the updates. So thank you again. Right, if I move on to item 9, children's service update. Are you doing that, Sharon? Yeah. Well, thank you, Sharon. So I believe we got the papers are on 89 of today's papers, And there's 20 minutes for this item, 10-minute presentation, 10-minute discussion.
Yes, I should have added. Thank you, Chair. My colleague, Jodie Ramcharity, is also here, who will be chipping in on the CAMS bit. That's all right. And I need to start by apologising. We struggled with this paperwork as far as the presentation was concerned, and I can see that certain bits haven't been deleted on it, so I apologise for the format, and we'll do better next time. But hopefully the report made sense. I'll just run through it and highlight kind of key bits for your information. We focused on key information we thought you would be significantly interested in. So we start with the IHA, and obviously so the purpose of the report really was to kind of update you on progress around IHA working, as well as give you an overview and an update on some of the other services within children's community, and also CAM services being delivered in the area. I think we've got a health report to the next corporate parenting as well, which some of the information is the same in here as it is in that report as well. So just wanted to start with background really around current position around IHAs and RHAs within Thurrock, because I know it's an area which everybody's interested in, and rightfully so. So I've just kind of put down there, we've just kind of highlighted the current data set around that. And obviously what you can see from that is IHA-wise, there's still room for a lot of improvement. Some of it is about resourcing. I think some of it is really around the need for myself and Sheila and colleagues to work together around processes as well. Because as you will see here, we've got 83% due to late paperwork, often linked to consent, and that's an awful lot when you're looking at kind of breaches. So we've still got a lot of work to do around that. But just going on really to talking about extra resources into children's IHAs. I've also put some information in there around RHAs, which is routine health assessments, because actually that is a good news story around our RHA and our kind of compliance with timings. So that needs to go down there as well. As you can see there, most of those are conducted on time. I've also added in there some feedback from young people that we've got in there. I think the other thing to say about feedback from the young people is we've recently employed a participation officer who will be linking in with the children looked after forums in Thurrock, especially around some of the developments around the new IHA model, and helping to look at a bit more kind of co-production around how we develop that model and take it forward within Thurrock. And they'll be getting in touch with your children looked after forums. The proposed new model, just to let you know, obviously this is really about trying to deliver more capacity within resources, but also looking at trying to improve the journey for the looked after child as well. And that will be via engaging the LAC nurses, as we call them, at an earlier position in the kind of journey of the looked after child when they come into care. So we'll be involving them in the IHAs as well as the RHAs. And the idea is that obviously if you look at the reason why there's some lateness, it's because of engagement with the young person. So really, if the LAC nurse can engage with the young person, told, oh, you need to go and see a doctor over there in that room, it's really about kind of improving the pathway for them and hopefully engaging them in their health from day one, as far as obviously the initial health assessment, but then obviously engaging in their routine health reviews and accessing their health needs at the earliest opportunity. So the new model involves utilising LAC nurse workforce to engage with children looked after and carry out initial IHA appointments, gathering relevant information prior to the review and sign off with the appointment with the paediatrician. So this means the appointment with the paediatrician, he'll have all the information before. It'll be a much shorter kind of period of time with the paediatrician, unless obviously there's complexity and things are raised there. And also they'll know what to expect more, because they'll be briefed on why the doctor's seeing them a bit more as well. The LAC nurse will support completion of the initial health IHA within the child's place of care, or most appropriate setting. And the second shorter appointment, as I said, with the review and sign off by the paediatrician to help with improving relationship building and also increasing the paediatrician capacity. So by reducing the appointments, we free up the number of slots they can actually have to kind of sign off IHAs. The new model is to be rolled out in stages across the MSc throughout 2026, and therefore we will keep you updated as we go along with that, the new model. So really that was just obviously to kind of update you and inform you around that. And then what we've done in Appendix 1 and 2 is giving you a bit of an overview of some of the children's services in Thurrock, highlighting some of the kind of good practice or kind of good news stories around the specialist health visitor, perinatal mental health investment that's been made in Thurrock, and also the enhanced infant feeding offer that's been made in Thurrock as well over the last 12 months. And I don't know what you want to pick up on under children's.
Just in terms of
Jodie?
Oh, sorry. Thank you. We're putting together a business case to do some joint working with the social care team in terms of new family support plan with a clinician that will cover both sides. That will, again, will look at engaging with young people from sort of the looked after arena, so that we can be able to engage at an earlier stage rather than waiting. So that's all in process, which falls in part of the future planning.
I think the other two things I'd highlight under CAMS is the bit around PCNs. So that's your mental health workers, children's mental health workers in GP surgeries, and delivering easy access to mental health services within GP surgeries, which is down there. And also the other bit around our mental health in schools, and a lot of the good work that they've been doing around expansion of the services within schools, making children's mental health services much more accessible within schools.
Yeah, just to add as well, with the MHSTs, they're on point to hit their 100% by 2029. So that's on cue as well, so that they'll be able to have MHST workers in all of the schools within the Thurrock area. So that's actually on point.
Yeah, just you're looking at, for those people who haven't got a background in their MHSTs, they were rolled out in waves. So actually, what Jodie's referring to is we're on track to have 100% coverage fairly soon within timescales, which will be good. Good for Thurrock, good for children and young people in Thurrock. Yeah, and I think the other thing to say around that is obviously the kind of role MHSTs and other kind of services will be linking in with some of the developments around more of a needs-led neural approach as well across Thurrock moving forward as well.
Thank you. I mean, obviously the issue about IHAs has been going on for probably as long as I've been in Thurrock, it's 7-8 years. So we've been struggling a lot as a system to try and get this improved, to get it right. Unfortunately, I'm curious about the figures because we have different figures in Thurrock. And we track the IHAs in particular weekly. So we have a weekly meeting, and the IHAs is for when a child newly becomes looked after, and we're not talking massive numbers. So they're numbers that we can easily track, and and keep an eye on. So I asked, obviously I saw this paperwork and I thought, that doesn't look, I'm not familiar with those figures. So here it's saying 83% are late due to paperwork. And paperwork, for people who don't understand that, is what the local authority sends to NELF to say, this child has become looked after and here's all the details and the information. And I think we've got a working agreement that we've got 5 working days from the time a child becomes looked after to get the paperwork to yourselves. And so the figures that we've got is that there's only 30% of the paperwork is not sent on time, and that in the same period that you've reported, we've got overdue IHAs being about appointments, and non-availability, if you like, of paediatricians is 49%, whereas I think in this report it's saying it's 8%. So
I just check, Sheila, is that just for Thurrock children? Thurrock children to
NELF,
Thurrock
yeah.
services? No, but NELF services cover Redbridge. I'm only reporting on Thurrock, Basildon and Brentwood in these figures. I'm not reporting on Redbridge and the other NELF services.
So I think that's a kind of a problem for this Health and Wellbeing Board, the Thurrock Health and Wellbeing Board, because we're sort of talking apples and pears in a way. So there's a figure here. So I mean, I understand what you're saying. So NELF's contract is for any looked after child that's living in your area, the NELF area. Obviously, from our perspective, it's Thurrock looked after children who belong to Thurrock, don't belong anywhere else. And I suppose the reason why I'm raising this is it's really important because we have been working at this, you know, system-wide for quite a long time. So it's still really disappointing to see those numbers as low as they are. And it has been raised by Ofsted again last time. It's been raised again in the SEND inspection, you know, as an area for improvement. And I suppose the problem with me seeing the figures the way they're presented, if it was 80-something% are just down to paperwork, I sort of think that should be fairly easy to solve because that belongs to the local authority. We can quite quickly go, if you look at the overall numbers of initial health assessment, they're not huge. Every month they're not huge. I think September was just 2. So they're not huge. So we should, you know, if it is paperwork as the main problem, we should be relatively easy to fix. So, and the fact that the new model that we're creating is giving additional capacity for paediatricians indicates to me that a bigger issue, I don't think it's 100% the issue, but a bigger issue is capacity and lack of paediatric, whereas this report is saying that's only 8% of the reason for late IHAs. So I suppose I'm looking at this thinking, you know, if it's for all looked after children that are not Thurrock looked after children, but I can give you, and the board, I can give you Thurrock looked after children data around IHAs. It's a little bit better than this, but obviously we've still got a big problem. But we certainly, from a local authority perspective, see the bigger problem being about paediatric capacity to respond to when we have a look. And you're right about the reviews. The reviews are much better because we've got a year. It's an annual review. So we have a year in which to make sure those children can get their review. It's the IHAs that bring pressure because it's got to be done in 20 working days. And if you've only got a contract for so many people, and that's what I was told before, the issue was you only have a contract for so many hours for the paediatricians to do IHAs. And we have had examples where children have become looked after and the referrals and the paperwork's done on time, but the actual first appointment you can get is way beyond 20 working days. So it was never going to be on time. And I certainly felt that everyone accepted that, and that's why we're looking at this new model and putting resource in so that you can increase your paediatric time, but also where it doesn't need a paediatric response, and that's the thing about having some looked after nurses, is much more sensible and proportionate response. Because some children come into our care and we've got masses of health information and they've been involved in hospitals, etc. other children, for example, some of our unaccompanied asylum seekers, we have no knowledge of their health needs. So there you do need that higher level of intervention. So I suppose I was just worried that this report paints a picture that this could all be resolved if the local authority's paperwork was sent in on time.
I'm really sorry if it gave that impression. I mean, IHS, as you and I know, is more complex than it looks at first sight, and there are lots of different reasons why things breach. I think it would be really useful if we agree one or two things. So the model will increase the capacity. I have to say the ICB have identified extra funding in order to put into IHS to improve the capacity. The issue we have is about the sporadic referrals. You know, you can't have paediatricians sitting there doing nothing. So some weeks you get 27 children looked after, the next week you don't. So there will always be a percentage of breaches, but it is about improvement. But one of the things it might be useful, so we can bottom out this data and your data, is if we give a commitment to actually sit down and review some of the data together. I think that would help as far as, you know, actually has been clear about data and processes. But on the other hand, as you say, it is about more paediatrician time. It is about improving the slots that we have, which is why the ICB have committed extra funding around that, which is now coming online. So that is in line until we get the new model up and running. But I suppose I was just looking at all of the different reasons for breach, because, you know, as I say, getting IHs to 0% would be the best thing ever, but actually if we can get as close to zero as possible by admitting and taking out some of the other percentages, as well as the extra paediatrician time, I think, you know, all of the things would be best for children looked after. So it would be really helpful, and I'd be very willing, together with our performance data, to sit down to kind of bottom out some of this as far as the kind of data for Thurrock. I also hear what you're saying about NELFT in general, when you've got Thurrock children who are going to Redbridge and what have you, and it's a NELFT service. The way that that's reported is confusing for yourself as well. Obviously, you know, like yourself, I'm only interested in Thurrock, Basildon and Brentwood, really, because they're the services I'm responsible for. But if it helps us to put some of that information together and look at it together, then I'd be very open to doing that.
Very keen to that to happen, because there's a big difference in your information, isn't there? So that's not helpful. So I look forward to the outcome of that. Okay. Margaret.
Thank you. Thanks, Sharon. I've gone through the papers in the pack really carefully, and I can see there's lots of connectivity with various physical health services and such like for looked after children and for other children, obviously, and clearly linking in with the schools. I'm a little bit surprised I haven't seen anything about access to dental services.
I think some of that is about the report and the report remit, in that obviously our health visitors and school nurses would obviously have some of that written in as far as a kind of psycho-ed and information giving. But we only picked some of the new highlights. So point taken. They do that, but obviously we haven't split down the report into absolutely everything that's done. But obviously I know they worked with the initiative that happened last year as well.
Councillor Rigby.
Thank you, Chair. Thank you. I've got a couple of questions, if that's okay, Chair. Firstly, just following on from Sheila and your discussion over capacity and the fact that you can't have a paediatrician employed who's just going to sit there 1 week with no children and then the next week lots of them. I'm sure you're looking into it, but what about sort of having like locum or on-call paediatricians that could be called in if there is a sudden surge, just to help deal with that capacity and sporadic nature of referrals? Is that something that would be a possibility?
That's one of the ways that we're using the extra funding at the moment. So what we've been able to do is to take on bank a GP IHA assessor. So we know that we can kind of book her in for extra slots to kind of soak up the capacity and keep any breaches to a minimum. both in NELF services and also in Provide. We're doing that at the moment.
So in theory, if the local authorities are submitting their paperwork in time and you can sort out the paediatrician issue, in theory it should be resolved. But what other issues are at play in that if it's not as straightforward as those two things?
So I think I think what we've mentioned are the kind of the two key issues. There are other issues in there. There are several reasons why children looked after aren't brought to appointments. Sometimes they don't want to come. Sometimes carers are busy and they're not able to make the appointment, and that appointment's within 20 days and the next one isn't. Sometimes it's also about the fact that they move out of area, so they might have moved in and then they move out of area, or they move in area. So they might have been made a looked after child, and obviously that's not the Thurrocks, but they might have been made a looked after child outside of area, and then they've moved placement maybe on the 19th day of their being a looked after child, and then obviously they come to us and obviously they'll be breaching straight away. So there are several reasons why we'll probably never get to zero breaches, but those two key issues that we've been discussing are the main ones that we can do something about, and we need to do something about.
Thank you. And I just wanted to ask about the CAMS. There isn't really any, well, there's no data here on waiting times. Is that something that you'd be able to get for us, please?
Yeah, shouldn't be a problem at all. We can get the waiting times to the next meeting.
I was actually going to ask something similar as to Councillor Rigby in terms of waiting times. What are they currently?
Sorry, sir.
What are they currently in terms of waiting times for CAMS?
I'm not going to pluck a number off my head. I've got so much figures. Presently, I think, based on the numbers I saw at the last meeting, we're probably I think it was 82% in sort of meeting our target. We know I can't give you the exact numbers, sorry, but I can at the next meeting. But we are within the target range of the expectations within our contract.
So that's 18 weeks. So that's 80% of referrals are seen within 18 weeks. Is that right?
Yeah.
Or 12?
12 weeks 4 weeks for urgent. So we are hitting 100% for urgent within 4 weeks, and it's 82% for the 4 weeks, the 18 weeks.
There's, correct me if I'm wrong, CAMS kind of raised the bar and standards in terms of their referrals, what criteria you had to meet for a referral. How's that gap being met? Because if there's an increase in, I can understand maybe people going into schools or families for relatively low levels, but for maybe more needed or challenging people who need greater support, how's that being met?
So obviously, as per our normal referral criteria, they'll go through our single point of access, and then they'll be triaged accordingly to our service if it's needed. We will then do the assessments to see, and then signpost accordingly. We'll pick them up to treat, or we'll signpost them to relevant services that will probably meet their needs better. It could be, I'm trying to think, in Thurrock, because I'm sort of new to the area, sort of local areas. Sorry, Sharon, we're thinking of
Do you want me to just come in, Jodie? I think twofold there. As far as raising criteria for entry, CAM services, and correct me if I'm wrong, Jodie, but CAM services haven't raised any bars. I think what they have done is kind of developed different delivery models for different levels of need. So you heard me mention and refer to the PCNs in here. So that means anybody who thinks they've got a child or parent who thinks their child has a mental health problem, or they're worried or they're anxious, they can actually go into the GP surgery and the GP, well, the ones with the PCNs can book an appointment with the PCN and see the PCN. There's no criteria for seeing them. They see most cases which are referred to them. If they're very low level, they might signpost them to kind of other organisations, but they have access at a GP level. Then, as I said, we've got mental health in schools. So mental health in schools also don't turn children away. They see all children or young people who might have concerns about their kind of mental health. And then obviously you have your therapy-based services, which are CAMS, the CAMS services. The one here is in Thurrock, just over the road there. And then obviously, if they come into that service and it's felt that they need more intensive intervention, then they'd be seen by either our HCRG element of our service, or they'd be seen by the CAMS specialist service.
Does that sort of make sense? I'm saying our local service here will pick up all the specialist needs and high-level concerns that young people may have within mental health. And then obviously it goes further than that. We will refer on to Tier 4 inpatient service if we think the needs are that great.
Okay. Is there any other questions? Kim.
Thank you. Within Health Watch, we obviously look young children, young people, and the access to mental health services has sat on our priorities for many years. It just does that full cycle, and every year it is back again. And I know what you're saying about the PCN levels, that there is access there to for children, young people, low level, and their parents. But we haven't got that service in Tilbury and Chadwell, have we? Because there hasn't been anybody in post since December 24. So for that PCN area, there isn't that service available for young people. And we have raised this and raised our concerns that it's building up in that area and it's not equal. They've not got an equal access. And those that need it more are being moved out to other areas. So they're being transferred to be picked up within other PCN areas, Corringham, Stanford, wherever, which then is having an impact on the young people in that area. So, I mean, it is in here. I didn't expect to see it in here, but it is in here, so fair play. That the post has been vacant since December 24 due to uncertainties with funding. We're now in 26. Is there any view at looking at that and making sure they do have access to somebody?
It's PCNs.
Is it PCNs that fund it?
Well, they're funded by the
is it an
GPs and the ICB. It is funded by the sounds of it, and I'm sorry, I will need to find out and come back to you because I don't cover PCNs.
Yes, so it will be funded. I think it's funded through the Rs.
Rs, yes.
So that funding is available and can be drawn down.
So instead of us being signposted to other people, we actually should be holding the actual PCN to account as to why they're not using that money, because I think there's a bit of smoke and mirrors going on here.
Yeah,
so that's fine.
So I guess we can dig into that, can't we? So maybe
please.
Margaret, we can have a look at that with the PCN in terms of, is it the PCN not willing to commission the service from NELFT, or has there been recruitment problems? Well, what's the issue? So we'll take that away.
Thank you. Thank you.
Any other questions? Right, could I thank you for coming on today, both of you, and feeding back and report, but I think it'll be useful to come back in 6 months' time, I'll be honest, because I feel there's some gaps I really would like a bit more information on, which would be really, really useful. We can have a bit more information about the mental health stats you've got, the waiting times, Thurrock people. I'll be interested in particularly about where people are signposted if they don't come to CAMS, and how that works. I'm interested in the dental care that our children are receiving, because it's really important in terms of we're trying to develop the best healthy population coming through today that we've ever had in the UK. So I'm really kind of interested in that kind of information. I'm interested in your figures lining up with the local authority figures as well. So could I ask if we come back in 6 months' time? Is that okay?
Yeah, that's fine. Then that's helpful to have kind of honed down clarity on what you want. Thank you.
Okay. Thank you again. Right. I think as a board we were asked to note the content of your report, which I think is noted. And if there's any other business, don't believe there is. Any other business? No. With that, then I declare the meeting closed at 15:40. Thank you.